So good afternoon, everyone. We're happy to get back to our sessions, and I hope we are going to have a very exciting session on the advances in PNH after a very quick lunch. I hope I didn't steal part of your dessert. That was kind of fast. And for this, we will have talks on the clinical and the biological aspects of PNH this afternoon. Antonio?
Thank you very much, Rodrigo. It's a privilege being here with all of you, a lot of friends, discussing all advances, not only in PNH, but in all bone marrow failure syndromes. We will have 5 talks today here. 2 of them will be on remote. Morag, Griffin, and Camilla Frieri will join on remote, whereas Regis, Peffault, Latour, Ronald, and Pedro, Prata are here and will give their talk in presence. So we can start with Morag Griffin from Leeds that will tell us about how to choose among C5 inhibitors. Morag, I think you are there, right?
Online. Can you hear us, Morag?
Morag, we can
like
see you, yes. But
can you hear us?
Yes, hi, thank you.
Okay, you have the floor then. Thank you very much for joining us.
Thank you for the very kind invite, and I'm so sorry I couldn't come over to the States. I'm Morag Griffin, Joint Service Lead of the PNH service in the UK, and I'll be covering how to choose amongst the C5 inhibitors today. These are my disclosures. So just a brief recap of PNH, which many of us are already aware is a rare and life-threatening disease. And you can see from the Kaplan-Meier on the right that prior to eculizumab being available, patients had an early mortality, and particularly this looks worse than some of our malignant diseases that we treat. The median age of diagnosis is in the 30s, but our youngest patient is currently 6, and our oldest is in their 90s. And so to weave a case through this, this was a gentleman who was in his 30s, he was 30 when he presented. He had a 2-year history on further provision of information of erectile dysfunction, hemoglobinuria, and iron deficiency anemia, which is very rare for a gentleman, particularly at this age. He was actually diagnosed by a trainee, which is not uncommon as the amount of lecturing we will do, with a hemoglobin of 65, a very high reticulocyte count, which I will come back to later, and an LDH over 10 times the upper limit of normal. He presented in 2004, and therefore the only treatment available to him was transfusions and warfarin. And you can see from the right-hand side, he had a very high PNH clone with a large GPI deficient population at CD24 and CD157. So PNH is a mutation in the PIGA gene, which is acquired on the background of bone marrow dysfunction, either aplastic anemia or less commonly myelodysplasia, but it may be very transient, and your average 30-year-old is not used to going to the general practitioner, and so the cytopenias may well have been transient. There's a clonal expansion resulting in loss of GPI anchor red cells in particular, resulting in complement-mediated intravascular hemolysis. We're all very familiar with the complement system, and I'm sure this has been brought up many times today, but CD55 and CD59 in particular are negative regulators of the complement system. Loss of CD55 results in C3 activation, and CD59 is the last complement inhibitor in the terminal complement pathway. This leads to uncontrolled complement activation, which in particular membrane attack complex formation with intravascular hemolysis, a release of free hemoglobin, and a rise in LDH. Nitric oxide scavenging results in the loss of smooth muscle relaxation, giving rise to common symptoms such as this gentleman having the erectile dysfunction, but as well abdominal pain, dyspnea, dysphagia, and chest pain. Leukocyte and platelet activation result in a significantly high thrombosis risk, and if not diagnosed, you can have end organ damage, such as chronic kidney disease and pulmonary hypertension. This is Korean data, which many of you will be familiar with. But patients who have PNH have a significantly increased risk of thromboembolic disease. And if you have thromboembolic disease, you have a 14-fold increased mortality compared to that of the general population. On the lower left-hand side, if you have cytopenias, so the overlapping aplastic anemia in PNH, again, compared to the general population, you have a 6.2-fold increase in mortality. And if you have renal failure, looking at the upper right-hand graph, you have a 7.8 times increased risk of mortality compared to the general population. Looking at high disease activity, if you have a high LDH associated with your PNH, again, your mortality risk is significantly higher compared to those that have a lower LDH, although we must remember that there are patients who have a reasonably well-controlled LDH and a high white cell population of PNH, but a significantly low red cell population of PNH. They are at risk more of thrombosis. So indications for C5 inhibitor treatment, this is the UK indications, but is fairly predominant worldwide, is thrombosis, transfusion-dependent PNH, hemolytic PNH with anemia, exceptional cases where considered appropriate, and those with PNH complications. And at the bottom, we have pregnancy, of which we would mainly use eculizumab. In the UK, with a population of around 67 million, we have about 40 new patients started on C5 inhibitors, which is our frontline treatment, a year, the majority of which do have intravascular hemolysis at 26, followed by 8 patients with thrombosis. Small number of patients pre-BMT, and we had 1 pregnant lady in 2022 to 2023. So our patient back in 2005 went on to the TRIUMPH study, did very well. He was randomized immediately to eculizumab and his transfusion requirements stopped. We stopped his warfarin after 3 months when his LDH was well controlled. And you can see from the right-hand graph, his hemoglobin actually normalized and his LDH came down very swiftly. In 2010, he had a breakthrough hemolysis with a quite severe episode of flu, associated with a drop in his hemoglobin down to 80 and a rise in his LDH up to 2000. And so where are we from a C5 inhibitor summary? We've been using them now since the original studies in 2004, 2005. We've just published our UK data in Blood with 509 patients over a 20-year period. Comparing that to the Korean publication of 80 patients treated with eculizumab and the larger 4,000, just over 4,000 patient cohort from the PNH registry data with 1,600 treated with eculizumab. You'll note the median age at diagnosis is very similar across all groups. And the history of aplastic anemia in those that are untreated with a PNH clone is much higher, representing the overlap between aplastic anemia and PNH. Patients with thrombosis, again, fairly similar across all the treatment indication groups. You'll note common symptoms mainly with anemia and fatigue as presentations, but I think all of the symptoms are included in that presenting features summary at the bottom. So in terms of survival, the UK survival data looks a little different now to what it did in at the start of the talk, but you'll notice that this is flipped. So on the left-hand side, the expected and observed data is much lower, but if you remove those patients with immunosuppression and bone marrow transplant for indications of aplastic anemia, then the Kaplan-Meier resembles that of near the normal population. I think this emphasises the importance of prompt and active management of aplastic anemia, particularly in those patients with PNH as well. The Korean survival data, they had 2 patients that had passed away. Looking at the PNH registry data between those treated with eculizumab and those not treated with eculizumab, clearly the patients treated with eculizumab do significantly better. And I think this emphasises the importance that treatment for PNH is not available in a vast number of countries worldwide. I think as a community, we need to try and rectify this. In terms of treatment outcomes, there is still a risk of thrombosis, even if you are on a complement inhibitor. It doesn't completely negate the risk, but also patients are living significantly longer and getting older, and you are at risk of other complications, such as having a cardiac event due to lifestyle factors. Neisseria infections, we've had 11 in the last 20 years. You'll notice from the bottom of the graph, hemoglobin 24 months after starting a C5 inhibitor is very similar between the UK and the Korean group, and this results in a transfusion requirement for some patients due to a combination of either extravascular hemolysis or the overlap of aplastic anemia. So in conclusion, I think we can all agree that eculizumab shows continued long-term safety and efficacy to improve the complication and related symptoms from PNH, and a 60% reduction in thromboembolic rate from the PNH registry data. I'm very pleased to say that where available in countries for treatment, overall survival remains high, and complications such as thrombosis and meningococcal infection are uncommon. I think we still need to emphasize as well, patients with aplastic anemia do remain with a higher mortality risk if they're on a C5 inhibitor. We now have biosimilars available, and these have been approved from the DAHLIA and the SB12 study, both showing efficacy and equivalency. And you'll see on the right-hand side the difference in approval for biosimilars compared to clinical trial new products, with the biosimilar requirements being more concentrated on the analytical and preclinical data. So our patient in 2017 was asking for further treatment options, and he entered the Alexion 302 study, which was randomization between ravulizumab and eculizumab. You'll see from the bottom graphs his LDH remained very well controlled, and he remains on ravulizumab with a normal hemoglobin, and he's delighted he managed to go on a 4-week holiday to South America and really noticed a significant improvement in his lifestyle. So the ravulizumab was approved following 301 and 302 studies, and the 301 trial being a naive study for patients on a 1-to-1 randomization between eculizumab and ravulizumab, and the 302 study for patients on a standard 900 milligram bi-weekly dosing of eculizumab. Both trials were non-inferiority studies, the advantage being that patients were on an 8-week treatment infusion rather than every 2 weeks. So this is quite a busy slide, but summarizes the 302 and the 301 primary endpoints, favoring ravulizumab, but the main improvements are the trend to less breakthrough hemolysis, mainly due to more steady and controlled steady and controlled C5 level. And you'll note that the breakthrough events, particularly for those patients that happened on eculizumab, had a C5 level which came above the 0.5 threshold. The long-term follow-up has been presented at ASH for the 301 study with a comparison of patients in the International PNH Registry. LDH control was maintained in 80% of patients, and for MAVE events, they were very low, I'm pleased to say, with a 1.4 per 100 patient years. For patients who were transfused, those maintained lack of transfusion at 53.9%, again, most likely due to extravascular hemolysis or underlying aplastic anemia, and 33% of patients have discontinued ravulizumab, partly due to patient choice. 8 patients have died, and some patients were pregnant with 4 pregnancies. And so the ravulizumab associated adjusted survival of 84.1% at 4 years, with a mortality of 3.5-fold lower compared to that in the untreated PNH registry patient cohort. We also have subcutaneous ravulizumab available in some countries, and again, this is a non-inferiority study comparing ravulizumab subcutaneously with IV ravulizumab. And you'll see on the right-hand side, LDH control for male and females was very comparable. C5 concentrations remained below 0.5 micrograms per mil, with minimal breakthrough events, 4 of which were associated with a complement activating condition. Safety was comparable, apart from, as you would expect, some injection site reactions. And so ravulizumab subcutaneously is a weekly dosing, but does give patients some independence from healthcare services. So how do we choose amongst the C5 inhibitors that we can currently use in various countries? For patients who are pregnant, we would continue with eculizumab IV bi-weekly. If they're on longer-acting ravulizumab, we currently would switch them back to eculizumab. For the majority of patients who are not pregnant, we can still use eculizumab IV bi-weekly, but the majority, I would say, have now switched over to ravulizumab IV every 8 weeks. Subcutaneous ravulizumab remains an option where available, but we also have clinical trial options for C5 inhibitors, which I'll talk about in a minute. Biosimilar eculizumab in the UK and Europe is just about to be available and has certainly been approved. So we will be switching over our patients who are on eculizumab, which is a small cohort now. We have crovalimab, a subcutaneous newer treatment option, which has smart recycling technology and therefore is a subcutaneous injection every 4 weeks. The Composer trial showed that the majority of patients had a mean normalized LDLH below 1.5 times the upper limit of normal, quite high transfusion avoidance rates up to 92%. Patients had hemoglobin stabilization at each 24-week interval. More recently, the pooled safety data presented at EHA with a combination of the Commodore 1, Commodore 2, and Commodore 3 trials showed a safety profile with crovalimab consistent with eculizumab, comparable between patients who are C5 inhibitor naive and those that switched from eculizumab to crovalimab. The patient cohorts were very similar, with similar demographics. We must remember that complex formation can occur with crovalimab, leading to a type 3 hypersensitivity reaction for those patients who are switching over from eculizumab or ravulizumab, with a median duration of up to 2 weeks and a median onset of 1.6 weeks, but the range of 0.7 weeks to 4.4 weeks. And so patient and physician education is important so that we can look out for these complications. The newer pozelimab cemdisiran combination has now been within phase 2 trials for a couple of years. This is updated data with 22% of patients who were randomized on a 1-to-1 between cemdisiran every 4 weeks plus pozelimab at 400 milligrams either every 2 weeks or every 4 weeks. So cemdisiran is an siRNA inhibitor which reduces or stops production of C5 in the liver, and then combining that with a pozelimab C5 inhibitor. These patients self-administer treatment and therefore again provides freedom from hospital environment. 21 patients maintained an LDH less than 1.5 times the upper limit of normal and an LDH less than 1 for the majority. Hemoglobin stabilization again for 20 out of the 22 patients. One of the patients needed a transfusion with an associated breakthrough event, and the other patient was anemic. CH50 was fully suppressed throughout, including during the breakthrough hemolysis event. And we do sometimes see this particularly on ravulizumab as well. 6 patients had a small number of treatment emergent adverse events, and the spaghetti plots show the well-controlled LDHs apart from the one event of breakthrough. And so our patient, although very happy on ravulizumab with a normal hemoglobin, does have quite a high reticulocyte count. And so I do present this patient to leading into the next talk. This patient is very comfortable, very happy on ravulizumab, but do we need to change his treatment because he has a retired reticulocyte count? He's working, he's very well, and I would argue that we should treat the patient holistically and not just the numbers, but he does present with some degree of compensated extravascular hemolysis. And so we've made significant progress with PNH in the last 20 years, but more recently in the last 4 or 5 years. Not all patients need a complement inhibitor, which I haven't had time to discuss today. Patient education and awareness of complications, and eculizumab has been life-saving, and I'm pleased to say in countries where available, PNH is now a chronic disease. Complications can still occur with patients even if they are on a complement inhibitor. We need to remain vigilant to infection risk, meningococcal risk, and thrombosis risk. We are now in a position that we have intravenous treatment every 8 weeks. Subcutaneous C5 inhibitors are likely to be approved in due course, and this provides patients with some independence as well. So thank you very much for your time, and I look forward to the panel discussion as well.
Thank you very much, Morag. I think we prefer to keep the question for the panel discussion, so Rodrigo, you may introduce our next speaker.
Okay, so I have the pleasure.
I have some conflict of interest.
All right. I have the pleasure to introduce Regis Latour from Hôpital Saint-Louis in Paris, who will talk about the proximal inhibitors and how to manage them.
Thank you very much. Good afternoon. I'm very pleased to be here. It's always a bit emotional for me because I was granted in 2009 from the MDS Foundation that allowed me to spend another year in Neil Young's lab, and I think it was determinant for my career. So I thought I have friends as chairs, but it looks like not. With the topics they gave to me, it's not really proximal inhibitors, but more should we use them alone or in combination, front line or second line. So it's not that easy. It's a burning topic. And as you will see, we have so many clues in the literature, so we really have to discuss, and we'll do this at the end. So those are my disclosures. So when I was thinking to this talk, I obviously need to go back to the targets and just quickly briefing where those drugs are acting. Then we will obviously compare terminal and proximal blockers, especially in terms of breakthrough hemolysis, because this is the main deal of the questions that have been asked. And then what we have at the clinical side. And finally, I will give you my own opinion on March 21, early afternoon, after lunch. And perhaps I would change, because you know French people are changing mind easily. But just to say that, again, this is something that is really, really, moving quickly. So first of all, and sorry for this just after lunch, I won't be very slow on this. But basically, in terms of complement inhibitors, we got those terminal complement inhibitors, ravulizumab, eculizumab, crovalimab that Morag presented to you. We know them since years, decades. And more recently, we have three new players, that are all acting at the same level. They're acting at the very proximal level of the complement activation. One is blocking C3, pegcetacoplan. Another one, factor B, this is iptacopan. And the last one, factor D, danicopan. So let's just come back to the complement cascade. I swear to God I will be quick. I don't want you to have an headache. Basically, you know that there is a spontaneous hydrolysis in the blood, and then the C3b is fixing on cell surface. Then there is this combination between C3b and factor B. This is an inactive pro-convertase. And in presence of factor D, you have the B that is giving BB, and then you are forming the C3 convertase, which is the association of C3b-BB. This convertase is going to cleave C3, giving rise to C3b, and when you have an enrichment of C3b, then you will have the C5 convertase going to C5, C5a, and then the MAC formation and the lysis. So basically, what we're going to discuss is iptacopan, one of the three ones. This is an oral drug. This is giving morning and evenings, 200 milligram. This is a drug that have been developed in monotherapy. And as you can see on the slide, this drug basically is acting on the site, is binding the site of factor B, inhibiting the function. So it's able to inhibit the function at the C3 convertase level, but also at the C5 convertase level. Then you have factor D, danicopan. Factor D has been developed only in association with anti-C5 complement terminal inhibitor, 3 times per day, oral drug. And as you can see here, anti-factor D is blocking the activity of factor D, so you don't have any enzymatic activity anymore, and so you're blocking the convertase C3. Finally, and the one that was developed the most quickly is pegcetacoplan. This is an anti-C3. This is a sub-Q drugs. This is given 2 times a week on a regular schedule. This is binding on C3 and then inhibiting the C3 convertase. But as you can see, it's more difficult on the C5 convertase level because you cannot inhibit the enzymatic sites while even if the drug is fixed on the C3. So then how it works and what is the difference between terminal and proximal from those drugs. So first of all, this is an untreated PNH patients. You saw from the previous talks, we don't have those regulators, so complement is constantly activated. You have obviously missing some regulators, so the amplification loop is working very well, and then you have an ongoing hemolysis during life of the patients with some flare according to the complement activation conditions, such as infection, surgery, and so on. So that was 25 years ago. And then came the terminal complement blockers. So as you can see, if I can come back, you see that we are blocking at the very last part. You see that all the C5 molecules are blocked. And you see at the down that we are still having a mixed hematopoiesis of PNH cells and non-PNH cells, let's say normal hematopoiesis that are still under pressure of the immune system, but still there. And as you can see, when we are giving those drugs, we have a, would say, original phenomenon, which is a deposition on the cell surface of C3. This is what we call the opsonization, the C3D opsonization, which is able to address the red cells that are opsonized to the liver and the spleen, and which is responsible for this so-called extravascular hemolysis that you see on the draw. So we have the coexistence in patients under terminal blockage of normal hematopoiesis, of PNH hematopoiesis protected by the terminal complement inhibitors, and by extravascular hemolysis coming from the phenomenon of terminal complement itself. Obviously, and you'll see in a minute, there won't be any extravascular hemolysis under proximal inhibition because you're stopping the drugs at the very proximal level. So now let's switch to it. If we go for complement proximal blockers, factor B, factor D, or C3, you see that then now you're blocking the entire cascade, so you're avoiding the C3 deposition at the cells. You see that on the flow cytometry plot. On the right side, there is no C3 deposition anymore, and more importantly, down and left, you see that the hematopoiesis is predominantly a PNH-based hematopoiesis. So in other words, and this is outstandingly important, under proximal blockers, the patients will have a almost unique hematopoiesis coming from the PNH alone. This has been well studied. On the left side, this is a Pegasus trial. This is, as you know, a randomized trials who compare face-to-face, head-to-head, the pegcetacoplan and the standard of care, which was eculizumab. And as you can see, baseline on the left, 16 weeks on the right. You see that the patients under pegcetacoplan are showing a almost 95% clone size in the blood. On the right side, this is a New England paper from last week, the iptacopan trial. In green, you have the patients who received 8 to 5 iptacopan. In blue, the control group, which have avellizumab and eculizumab. And you see that at the end of the primary endpoint period, 24 weeks, the patients were presenting an almost 95% clone size PNH. So this is something that we really have with all proximal complement blockers. If you go to the alpha study, the danicopan study in association with terminal blockers, you will have exactly the same phenomenon. So we may think that the protection of the PNH on the intravascular side as well as no creating extravascular hemolysis might be the only phenomenon that explains this increase. I think there is many others, and we are still trying to discover what's going on under proximal inhibition. So now if we come to the breakthrough hemolysis phase, you have your, let's say, untreated patients at the top. An ongoing intravascular hemolysis, not control, responsible for thrombosis. Patients were dying, 1 out of 2 because of this. That was 25 years ago. On the right side, you have the terminal complement blockers. You still have normal hematopoiesis, about 30% of the blood. You still have extravascular hemolysis, again 30%. That is still going on because you have this C3 deopsonization, and then you have this addressing to the liver and the spleen, and this ongoing extravascular hemolysis. And you have obviously breakthrough hemolysis that is expressed on the other 30-40% of the blood. On the other way around, when you're speaking about proximal inhibition, then you have a hematopoiesis that is almost only PNH based. And if you have a breakthrough, if you have an uncontrolled complement activation, then you will have possibly a massive hemolysis with all the consequences of this because of the pathophysiology of the proximal blockers. So let's now come to the complement level. And I'd like first to apologize in front of Ronald Taylor because I think that what I'm going to say might be highly criticized. But anyway, if you're on a complement terminal blocker situation, everything is okay, no problem. Then you have a breakthrough, let's say a flu, a vaccine, whatever. You see that some of the molecules of C5 are not blocked anymore, and then you have a breakthrough, but in terms of intensity, that might be a little bit low or not that high that if you have all the cells to destroy. On the other way around, if you go to the right side, in a proximal blocker situation, you have a blood that is coming almost all from PNH. If at the time you are out of control, if at the time you have a complement amplification condition that makes the drugs have a burden or whatever, if you have a C5 convertase formation, then you will have a very different situation because we are, as hematologists, always forgetting that at that stage, there is the amplification loop. In other words, as you can see, one molecule of C3 is giving rise to several molecules of C5. This is a massive complement amplification, and this is very quick, this is very short, and if we are not reacting quickly, you see what's going on, we will have a massive blood hemolysis, kidney dysfunction, and so on, intensive care unit, and all the things that are coming with. So that's the way, at the moment, on March 21, early afternoon, we think we understand how it works. So now let's come back to clinic, now that we know what can happen. Let's come back to clinic and what we have as, let's say, clinical data. First of all, the Pegasus trial that has been published in the New England Journal for the first 16 weeks, and then in the Lancet Hematology for the 48-week extension study. As you can see, it's working outstandingly well. You're targeting patients with clinically significant extravascular hemolysis. Hemoglobin level is coming back to normal. Patients are not transfused anymore for 80% of them. Quality of life, wonderful. However, on the 13 patients who stopped the drugs at weeks 48, 6 of them stopped the drugs because of very severe breakthrough hemolysis. And at that time, there was a lot of noise because basically we didn't know what's going on. We didn't know what happened. I remember perfectly with Pete and others that were dealing with those patients, we were calling ourselves trying to understand because we didn't know all what has been presented before. And that's the moment we were, of course, discussing as a community, trying to find solutions. And basically we learned that when the proximal complement blockers are overburdened, when you have some complement amplification conditions, you have to react outstandingly quickly to avoid what I told you before, this massive, early on, very quick complement activation, which is enzymes based and not mechanically based like C5 and MAC formation. So first of all, it was Sobi who designed these prospective clinical trials. As you can see, there was different regimen of, let's say, management of patients with acute hemolysis related to complement amplification conditions or not. And as you can see, there was two options. One was to inject immediately an IV dose of pegcetacoplan, and the other one was to inject 3 times a row, 3 days a row, sub-Q injection of pegcetacoplan, and then to come back to a 3 times a week regimen, and then to come back to normal. And with that, as you can see, at the top of it, you can see, no you cannot, now you can, all the breakthrough hemolysis were able to be managed. Nobody stopped the drugs. And as you can see, the intravascular hemolysis, which was the case when it was a dramatic complication, was controlled and everything came back to normal. There was only prospective clinical trial patients on an extension basis from Pegasus, Prince, and Paddock, which was the primary studies with pegcetacoplan. In the same time, we, with our UK friends, retrospectively analyzed all patients who received pegcetacoplan on a real-world basis in France and in UK. That's a paper that just came out, like the one before. So you see the literature is just burning. It's just now that is appearing. We look back on 48 patients. 12 of them have been treated in clinical trials, so we were looking at them after. There was almost 2 years of follow-up. Those patients have been obviously treated because of clinically significant extravascular hemolysis. The majority were transfused, and basically it was PNH, so some of them have an history of aplastic anemia. The first thing is that on the efficacy level, we reproduce exactly what has been published in prospective clinical trials. We gain 2 gram hemoglobin in those patients. We control extravascular hemolysis with a drastic reduction of reticulocytes. And the good news was that on the safety side, we didn't have a bad surprise. We were able to manage the breakthrough, and we were managing them by reacting quickly. So the way we were doing it is to increase the frequency of the drugs immediately, if they have fever or whatever, immediately. And then if the patients needed transfusion, he had a backup of C5 injection because of what I told you before, is that if you have one C3 that is activating many C5 molecules, you need something down to stop the system. And just anecdotal, but it's important, none of the patients presented a meningococcal infection, and we have only 1 thrombotic event in the patients after a plane trip and so on, so nothing that would be quite surprising. So I spoke about pegcetacoplan data from clinical trials, real-world data. Let's now come to clinical trials with iptacopan. I'm just showing one slide because I don't want to repeat myself, and I don't have time to enter into details. You know this study. It's a 8-to-5 randomized trial who compared iptacopan oral monotherapy to standard of care, ravulizumab, eculizumab, for 24 weeks. As you can see here, the curve are almost the same than pegcetacoplan. Patients are coming back to normal hemoglobin level. Again, transfusion was not a problem. The majority of the patients were transfusion independent. Quality of life was outstanding. And the good news is that in that trial, 24 weeks follow-up, short. We have no discontinuation because of a severe hemolysis. Antonio presented the 48 weeks data at ASH, which are also reassuring. And in the New England papers, there is also the first line patients, 40 patients who were treated. And again, we didn't face any hemolysis. And for the alpha study, that is a poster outside, so you could go into details after the session. You can see that again, this is a randomized trial, but it was an add-on. Danicopan was an add-on to ravulizumab, eculizumab, so it's a combo. And you see that the drug was also aiming to increase hemoglobin level, coming back to normal hemoglobin, and all the things, transfusion independence and quality of life. And in that study too, there was no discontinuation for severe hemolysis. So now, my opinion. So first of all, should we use a monotherapy proximal inhibition or a add-on strategy? Honestly, theoretically speaking, it should be better to use an add-on strategy. Because as I told you, we will be sure that in case of breakthrough, the C5 will protect the patients from dramatic, massive, dangerous breakthrough hemolysis. However, we don't know what's going on with the patients who will be completely blocked at the terminal level, proximal level for years. Remember that the complement is outstandingly important in autoimmune disorders to protect us against autoimmune disorders. Complement, there is a huge bench of literature coming in on cancer, infections. So we don't know yet, well, if we should do a combo or not. The other thing is that on the monotherapy side, you see that we have some reassuring data, even from a real-world basis. 50 patients treated real-world, UK, France, with no problem. We have the iptacopan data that came out last week, who are very reassuring and showing that it's working very well. The patient's treatment burden is also an issue. I don't know if my patients wants to come every 2 months in the hospital and then take a pill 3 times a day. And the last thing, obviously, is the economic burden. Those treatments are outstandingly expensive, and we may imagine that if there is a combination, it will be higher expensive than one alone, but I'm not an economist. So for all those reasons, I will choose monotherapy. It's my opinion. We can discuss, no problem. And I do think that what we should have is like diabetes patients, you know, a kind of syringe with C5 as a backup. And then if you have a breakthrough, you do your injection of C5, at least you are protected. This is highly discussable. This is what I can say today with what has been published. I don't like to speak about things that have been presented in Congress, just papers. So that's what we have. So monotherapy. And then first line or second line? Well, it's true that we have 30 to 40% of our patients under terminal complement inhibitors that are presenting clinically significant extravascular hemolysis. However, it means that 60 to 70% of our patients are doing great under C5 inhibition. We know this C5 inhibition since decades. We know it's safe. We know how to manage. We know how to do. On the other way around, for proximal inhibition, we know since years. The data are generated. So you see that, well, we know that there is this breakthrough hemolysis target. We know how to manage, but it's very, you know, it's new. The patient compliance, I mean, I don't know you, but each time I'm saying to my young patients while taking iptacopan or oral drugs, be careful. If you're stopping the drugs, you can have a massive hemolysis or stuff like this. They are just laughing. They don't know the disease. Oh, please. Oh, my God. Ooh, ooh. And yes, but basically, if the PNH hematopoiesis is only PNH, if they stop the drugs, it will be a massive hemolysis. And the last thing is pregnancy, surgery, and all these things that we know how to manage. We have many families with babies because of eculizumab, and that I think at the moment is a bit early for proximal inhibition, so you understand that I'm more in favor of second-line treatment. So these are my opinions. I will stop there. I will, of course, thanks all my colleagues locally. I will also thank very much the FBI BMF interest group. You know what it is? It's the French, Brazilian, Italian.
Thank you very much.
Thank you for your attention.
Thank you very much, Regis. Thank you very much, Regis, for your outstanding talk. I know you're not an economist, but I hope you pay taxes still, right?
You know that in France everything is free.
Antonio.
Well, in Italy, I'm not sure we pay taxes. But anyway, this is a different topic. Okay. Some, not enough. Okay, so let's go back to science and medicine. And it's my privilege introducing Camilla Frieri, who is a young, next generation scientist, I would say, NGS, working in my place in Avellino, but he also had a very great training in Paris for a couple of years, and she will speak about the role of transplant, because don't forget that all the treatment that Morag and Regis were alluding to so far are not curing the disease. So the only cure for PNH could be transplant. Camilla, the floor is yours. Thank you.
Good afternoon, everyone. Do you hear me well?
Yes, yes.
Yes. Do you see my presentation?
Yes?
Okay, perfect. Thank you. Before starting, I would like to thank the organization for this great opportunity. It's a true pleasure for me to be here, even virtually. So my topic is about a very hard question in 2024. Is there a role for transplant in PNH? So the answer is apparently easy because we know that transplantation is the only curative treatment for PNH. But probably the topic is more complex because we know PNH is a complex disease. As you can see, PNH is classified in three main groups. The first one in red is classical PNH. That means our patient has a significant PNH clone with all signs of hemolysis. In green, you can have at the opposite subclinical PNH. That means our patient has a very small PNH clone, usually associated with a bone marrow failure syndrome like aplastic anemia. So in this case, you don't find signs of hemolysis, but you find, for example, cytopenias. In the middle, we can have like a gray zone, PNH associated with a specific bone marrow disorder like aplastic anemia, myelodysplastic syndrome. In this case, you can have at the same time signs of hemolysis, but also a certain degree of cytopenia. PNH presentation can be different from patients to patients, and also in the same patients, you can have different presentation during the life. In a poetic vision, if I can, PNH presentation are like different colors. So our patient can move through different colors. Different colors are different presentation. So if we have a different presentation, we need different therapeutic strategies. I think it's very useful, this kind of therapeutic algorithm made by Antonio Risitano and Regis Peffault de Latour. Just to introduction, here we have GPI-AP deficient population, that means PNH clone. On the left, you can have classical PNH with hemolysis, thrombosis, so the first line treatment are complement inhibitors. On the right, you can have subclinical PNH in the context, for example, of aplastic anemia. So in this case, you can choose between immunosuppressive therapy or transplant according to patient's age and donor available. But keep in mind this schema because we will resume after at the end of my presentation. So PNH is a dynamic disease and therapeutic approach is a dynamic process. But we need to take a step back to try to answer the initial question. Just for curiosity, the first report about PNH and transplant was made by Professor Storbe in 1971. This was a clinical case about a very young guy with severe aplastic anemia with a PNH clone associated who underwent bone marrow transplant from his sibling. I think this is an incredible story because when I studied to prepare this topic, I discovered that this patient is still alive after 47 years from transplant. So when we talk about PNH and transplantation, I think it's important to distinguish the pre-eculizumab era and the eculizumab era. The first report was made by Sasso and colleagues in 1999. This was a retrospective analysis about 57 patients with PNH transplanted between 1978 and 1995. As you can see from the table, in 32% of patients, indication to transplantation was severe aplastic anemia. In most of cases, the donor was an HLA identical sibling, and as you can see, conditioning regimens and GVHD prophylaxis were very heterogeneous. So the 2 years probability of survival was about 56%. As expected, there was a difference in terms of survival in case of sustained engraftment or not, and main causes of death were graft failure and infections. Here we have all series about PNH transplanted patients never treated by eculizumab. As you can see, between indication to transplant, we can find all types, all kind of presentation of PNH presentation, classical PNH, PNH in the context of bone marrow failure syndrome. The largest series remains that made by Regis in 2012. This is a retrospective analysis about 211 patients transplanted between 1978 and 2007. The authors compared this group with a cohort of 402 non-transplanted patients. The goals of the study were to analyze overall survival and also to compare the occurrence of complication between two groups. As you can see from the table, number 1, indication for transplant were severe aplastic anemia, recurrent hemolytic crisis, thrombosis, but we have also a few number of patients transplanted for myelodysplastic syndrome and acute leukemia. In table number 2 are described all characteristics of non-transplanted patients. The 5 years overall survival probability was 68%. Main causes of death were infections and GVHD. And as you can see from the figure, there was no difference in terms of survival according to the donor. So no difference between related and unrelated donor. Probably the most interesting point of the study was the survival analysis according to the transplant indication. As you can see from the figure on the left, patients transplanted for a thrombotic event had the poor outcomes compared with patients transplanted for aplastic anemia and recurrent hemolytic crisis. And there was also a difference in survivals in case of thrombotic event between the two groups. So between non-transplanted and transplanted patients with a poor outcome in case of transplant. In a sub-analysis about patients transplanted for aplastic anemia, as you can see, there was a difference in survival according to the delay of diagnosis. That means, you know, the earlier, the better. And also to time, according to time to transplant, probably because we know transplant procedures are improved over the time. And there was no difference in terms of survival according to the source of stem cells. That means no difference between bone marrow and peripheral blood. So the only significant predictor of survival in case of transplant was the indication to transplantation, with patients transplanted for a thrombotic event having the worst outcome. Here we have all series about PNH transplanted patients previously treated by eculizumab. I think it's important to do 3 main observations. The first one, as you can see, number of cases. The number of cases has dramatically reduced over the time because of the introduction of complement inhibitors. The second one, between indication to transplant, as you can see, we can find only clonal evolution, bone marrow failure syndrome. We don't find, as previously, for example, classical PNH. And how to manage eculizumab, as you can see, is very heterogeneous because probably we don't have guidelines about that, how to manage eculizumab in pre-transplant period and post-transplant time. The largest series was made by Valle and colleagues. This is a retrospective analysis about 21 patients previously treated by eculizumab and transplanted between 2007 and 2017. In table number 1, we can find all characteristics, all patient characteristics. In most of cases, indication to transplant were aplastic anemia and transfused classical PNH. The estimated cumulative 6 years overall survival was about 68%. Main causes of death were again GVHD and infections. And with the limit of the retrospective study on 21 patients, the authors conclude that eculizumab seems not to change the risk of transplant complication. So now we can come back to the first slide. I try to update this scheme. So if you have a classical PNH, you know, with hemolysis, thrombosis, and so on, now we have as the first-line treatment complement inhibitors, anti-C5, eculizumab or ravulizumab. I think is very important in our clinical practice to evaluate the response to treatment. One useful tool that we made with Antonio Risitano was response category. That means because it's important to identify poor responders and also to find out causes of residual anemia. If you have, for example, a residual intravascular or extravascular hemolysis, we know that now we have other therapeutic options like pegcetacoplan and iptacopan, or obviously also investigational complement inhibitors. On the other side, if you have a subclinical PNH in the context, for example, anaplastic anemia, moderate or severe, you can choose between immunosuppressive therapy, but now we have also eltrombopag to add to cyclosporine and ATG that we know improves hematological response. And you can choose between immunosuppressive therapy or transplant. We know that the best donor remains the sibling donor, but it's important to underline that now we have a lot of clinical ongoing trials about alternative donors. In conclusion, the first observation to do that we have only retrospective data about PNH and transplant. So sometimes I think it's difficult to give a definitive answer, but who to transplant? I think we probably agree that an indication to transplant remain for patients with a subclinical PNH in the context of bone marrow failure syndrome, and also in patients with clonal evolution in myelodysplastic syndrome and acute leukemia. I don't know if there is still an indication in transfusion-dependent classical PNH, because as you can see, we have other therapeutic options, also novel complement inhibitors, and also for patients with the recurrent thrombotic events, probably for two main reasons. The first one, that the incidence of thrombotic events with introduction of complement inhibitors like eculizumab has drastically reduced, and also due to poor outcome in case of transplant. How to transplant PNH patients? I don't know if we can give a definitive answer also. As you can see from the previous series, there was no difference between related and unrelated. There was no difference according to the source of stem cells. And what about conditioning regimen? Probably the only series that compared reduced intensity and myeloablative conditioning regimens was made by Cooper. And as you can see from the figure, there is no difference in terms of survival probability between RIC and MAC strategies. And the last point, probably the hardest point of the discussion, is the cost and availability of complement inhibitors, because we know that complement inhibitors are very expensive and we don't have access to complement inhibitors worldwide. So I think there are a lot of countries where transplant remains a good option, and probably the best option for PNH patients, young and selected. Thank you for your attention.
Thank you very much, Camilla. Very comprehensive study, and I hope that you will be able to complete your ongoing study with EVMT, looking at the past 10 years, just to have a snapshot of transplant nowadays. So after that, it's my privilege in calling here on the floor Ron Taylor, because if we have all these good drugs for PNH treatment, is because of the help of the complementologists, because as you know, we hematologists are not very familiar with the complement cascade. It's an headache, and thanks to Ron and many other people, I think now we are very successful. Ron, the floor is yours.
Many of you, some time ago, when you were in medical school, were subjected to a short, agonizing talk on complement. I'm here to bring you back. So my disclosures. I have no conflict of interest, unfortunately. I'm going to have a lot to say over the next 20 minutes. I want you to understand complement opsonization and the thioester trap. Many complement proteins are sequentially and very rapidly activated before and after you form that trap. At the molecular levels, we want to know about complement activation and regulation. And then the therapeutic strategies are, do we want to activate complement and kill the bad guys, or do we want to block complement and save tissue? And you'll see that in addition to targeting certain targets that you've already heard about, I'll tell you about targeting C1s, factor B, and factor D. So complement, it's a major component of innate immunity. It's the first responder in the bloodstream. It's described by Jules. Okay, this is not built for short people. It was first discovered by Jules Bordet in 1894. He lived until 1961, and as best as I can tell, he never made contact with any of the more modern complementologists. But it's an interesting study, interesting gentleman. Complement recognizes and destroys a lot of dangerous intruders, and that's the right word. Bacteria, viruses, parasites, fungi, which may or may not be opsonized. And this is terribly important. You can have antibodies opsonizing the bad guys, and then complement gets activated, but complement can also spontaneously opsonize the intruders, and that's even better. And the point is that there'll be a covalent label on the intruder, and then it can be eliminated. And if complement is dysregulated, it can recognize and destroy self-tissue. You know that the complement pathways are very easy to understand. And in fact, many investigators have published schemes on complement, myself included. And if you work on complement, all these schemes are very easy to understand. If you don't work on complement, they're incomprehensible. So with that in mind, I will focus on what I think you should know, and the rest of it, don't worry about it. The thioester label in particular. The intruders are covalently labeled by C3b and or C4b when an internal thioester linkage is broken. The internal thioester linkage is in C3 and C4. It's broken and then it's converted to an amide or ester bond bound to the invader. This labeling serves as a very rapid and efficient targeting of the intruders. So what do we have here? We'll start with C3, and what I'd like you to see is that C3 has an internal thioester bond. When C3 is activated by a protease, the C3 suffers a major conformational change, exposing the thioester to the solvent. Well, if the thioester reacts with water, that's not particularly interesting, but some 10 to 30% of it will instead react with a substrate. It can be a protein bound to the invader, it can be a OH group or NH2 group on the invader, and then it's C3b opsonized, and that's very good because then you can get rid of it. So in the second step, we're going to form the C3b, the ester or amide bond. Here I've just shown an ester bond. So here we have a bacterium being opsonized. The bacterium is recognized by the first component of the complement pathway. I'm not showing all of them because again, as I said, you don't have to understand all of this. So there's going to be a recognition, and then there's going to, by C1q, which is part of the C1 complex. C3b will deposit, multiple C3bs deposit, and then I think we're running out of electricity here. And then finally, C5 will be cleaved, and the membrane attack complex will cause lysis of the bacterium, and you're very happy about that. Now, the C3 and C5 convertases are unstable and can rapidly dissociate, thus stopping complement activation, which is a natural control. Well, the question is, how can we manipulate the complement cascade to treat disease? In particular, if we want to activate complement, we'll do that, and we'll kill the bacteria, viruses, or the cancer cells, usually with monoclonal antibodies that activate complement. I feel like I'm running for office with this photographer here. I better leave that subject alone. All right, so we want to kill the bad guys, and in particular, I'm going to tell you a little bit about our work where we used anti-CD20 monoclonal antibodies targeted to the B cells in chronic lymphocytic leukemia. So complement simplified the classical pathway. Antibodies bind to cell surface epitopes. C1q binds to the oligomerized antibody FCs. C3b is then covalently deposited on the cell, and then you can get cell lysis because the membrane attack complex forms, and then it will poke holes in the cell. Or alternatively, and especially important with respect to PNH, there could be extravascular cell clearance, which was first discovered, of course, by Dr. Risitano. So how fast and how much? These numbers are just incredible. One C3 that's activated can get you to about 30 C4Bs. That can get you to 1,200 C3Bs. But then it keeps going because there's an acceleration in the alternative pathway. You can get to 2 million C3Bs deposited on a substrate, on an attacked cell, in about 5 minutes. Now you can see if you're attacking your own tissue, this is catastrophic. But if you're attacking a bacterium or virus, it's a great idea. So this can be followed, you'll see in real time. There are also several amplifying autocatalytic steps that you'll see participate in the alternative pathway. And as John Lambris has written, opsonization with C3b marks the starting point for the generation of a series of potent effectors with the aim of facilitating the clearance of the targeted particles. And you could understand a system that's this lethal must be regulated to prevent attack on normal tissues and cells. So to examine the efficacy of complement, you'll see that we can image cells and follow the C3b deposition reaction in real time. And the model for this is rituximab and ofatumumab treatment of CLL. We're going to look at B cell lines opsonized with anti-CD20 antibodies reacted in serum as a source of complement. And if we can get the audiovisual to work properly, you'll see we can do this in real time and do it to movies. And when cancer cells are killed, they don't die quietly. They die to very beautiful music. And you'll see that soon enough. So first of all, we just looked at C1q binding. We reacted Dowdy cells with purple, that is Alexa 647 labeled ofatumumab, an anti-CD20 antibody. And then we came back and reacted the opsonized cells with Alexa 648 labeled C1q, a green antibody. And you can see there's just exquisite co-localization of the C1q with the ofatumumab. So that's pretty impressive. And this really follows the paradigm that we would expect for complement opsonization. Now we're going to look in 4 colors at once via confocal microscopy. And we were able to demonstrate that ultimately it is the entry of calcium into a cell that kills it most rapidly under conditions of complement attack. And so you can see the calcium concentration, sorry, let me go back. The calcium concentration can go way up when you're attacking. So we're going to use a C3b antibody, 37, colored blue with a blue dye, that will recognize C3b when it's deposited on the cells. We'll use fluo4, which is a calcium indicator, and it gets brighter and brighter green as the concentration of calcium increases. We're going to use tetramethylrhodamine methyl ester. That's a dye that localizes to mitochondria, and it provides an index of live mitochondria. When the mitochondria are killed and poisoned by calcium, they lose the red color. And finally, we use topro3 as a live dead indicator. Topro3 is a purple dye, and it will enter the cells as they're dying and give a purple color. So we're going to look at 4 changes in a number of colors as a function of time. And what we're going to look at, I'll show you a particular cell that will show this. There's the cell, that's 1 minute. So lots of C3b is deposited on it. It's starting to die. Look at see the purple color? And so it's dead, and this is very, very rapid. Some of you actually might even recognize Tchaikovsky if you listen carefully. All right, so now we're going to look at the same reaction, but this time we're going to look at what happens to the mitochondria. Here's the same cell. You didn't know that Dvorak was a complementologist, did you? So now let's look at what happens. Time 0, the cells have no color. After 90 seconds, you can, I'm not sure this is working very well. After 90 seconds, you can see that C3b has deposited. After 180 seconds, they're starting to turn purple because the topro3 is entered. And at 225 seconds, they're highly dead, very well dyed with the purple. Now let's look at the green, the C3b. Looking at fluo4, which is the calcium indicator. By 90 seconds, you can see the cells are bright green. That's because calcium has entered the cells and the fluo4 has turned bright green, but the mitochondria have not yet been compromised. And then by 180 seconds, most of the fluo4 has leaked out of the cell, and you already know it's pretty much dead. And now finally, looking at the mitochondria, you can see they're red over here and here, but by 180 seconds, they've been bleached out at all. The mitochondria have also been killed. That concludes the musical portion of my presentation. So now, let's talk a little bit about the alternative pathway of complement. It provides fantastic amplification, and Mike Pangburn has recently written a review. He was the one who first discovered the amplification pathway, and in his review he admitted he always had some questions as to what it was he discovered, but we all take it at face value that it occurs. So the point is that there's foreign service amplification, that is, foreign services will activate complement and deposit C3b. Or the classical pathway will also give you C3b. And then C3b combines with factor B to form a complex which is reacted with factor D. Please bear with me. This painful part will be over soon. And then finally, you can make C3b, and you make more and more C3b, which autocatalyzes generation of more C3b again. So this is why you can go from 1,500 C3b to a couple of million C3b on the cell. So the alternative pathway obviously is playing a role as well. So the question is, how can we manipulate the complement cascade to treat disease? Well, we'd like to block complement and prevent complement-mediated damage to cells and tissues. PNH, I really don't have to say much about it. Atypical hemolytic uremic syndrome, I'll have something to say about that. C3 glomerulopathy, IgA nephropathy, and idiopathic immune complex-mediated glomerulonephritis, and finally, cold agglutinin disease. So these are a number of diseases in which complement plays a key role in the pathogenesis. So complement fast and furious. You've seen targeted cells can be killed very quickly. There must be on-off controls. Ideally, complement must be held in a quiescent state, turned on when needed, and turned off after it kills the intruder. So what does Peter Garrad say about this? Deficiencies or loss of function, mutations of complement may lead to infection. I'll show you more about that in a minute, or autoimmune diseases. However, the main reason for acute complement dysfunction in the clinic, which can be life-threatening, is an imbalance related to enhanced activation of the system. So we want to consider blocking complement, and the question is, if we block complement, are we going to presage infectious diseases, or is that not such a problem? The cascades can be harmful can be compared to undetonated bombs. Normally they do no harm, but if they explode systemically, as in sepsis, they might indeed kill the host. So complement deficiencies and dysregulation. We all know that C1, C2, or 4 deficiencies can lead to an SLE-like syndrome. Apoptotic and dying cells need to be opsonized by the early complement components. If they're not opsonized, then one can generate antibodies to histones, to double-stranded DNA, and have a lupus-like syndrome. A lack of C3 or any problems with C3 leads to pyrogenic infections. Almost all patients with homozygous C3 deficiency have been young children with very severe bacterial infections. And finally, downstream, factors B and D and the other complement components, Neisseria infections. And as John Atkinson has written, until the development of antibiotics, the survival of a baby with a deficiency of an alternative pathway complement component was unlikely. So the question is, will it be safe to block any of these proteins? Well, you already know it's safe, but we can now understand why as well. Well, innate immunity is supplemented in adults by antibody-mediated immunity. Antibodies can promote phagocytosis and neutralization of bacteria in the absence of complement. Patients undergoing John Lambris has written, patients undergoing C3 inhibition therapy will likely need to be immunized against certain bacterial diseases, and you saw a little bit of that in the earlier sessions. There's no evidence pointing to a vital role for C3 in adults who have a fully developed adaptive immunity. And this is John Lambris, who has developed the Comstatin series of proteins, of peptides, already approved for PNH and now under investigation for a number of other indications. Well, diseases associated with excess uncontrolled complement activation include PNH. What else is there to say? Other kidney diseases, I already mentioned a number of them with excess alternative pathway activation, and then cold agglutinin disease, which is what I'm going to start with because fortunately nobody's mentioned that yet. So targeting complement, cold agglutinin disease. IgM antibodies bind to red cells and they activate the classical complement pathway and deposit C3b. The opsonized red cells are removed by extravascular hemolysis. Does that sound somewhat familiar? I hope it does. The solution in this case is to target C1s with sutimlimab. I always have trouble with that. I just call it subtle. So let's look at this. You have IgM binding to a red cell. It will activate C1s, and then C1s will activate C4 and C2 to the C3 convertase, finally getting you to C3b. When not one, but maybe a million C3bs are deposited, that's enough to lead to extravascular clearance of the cells in the liver and the spleen, or alternatively, occasionally in cold agglutinin disease, the C5 convertase is activated and the cell is lysed directly. So how are you going to solve this problem? Block here with subtle, and then it'll work very well. So subtle was approved by the FDA in 2022. Patients are required, there you have it, to be vaccinated against Haemophilus influenza and several other forms of bacteria. A recent study demonstrated normalization of key variables over at least 79 weeks. So what I'd like to see is that when the patients got placebo, nothing happened. When they got the antibody, the hemoglobin levels went up to almost normal levels. Or alternatively, when the placebo patients were finally switched over to get the antibody, they rose up as well. So this is a fairly lovely and very effective treatment for cold agglutinin disease. And then similarly, bilirubin, which reflects destruction of the red cells, bilirubin levels remain high in the placebo, but when you treat, the levels go way down, and if both groups get the antibody, again, bilirubin levels remain low. And this is Dr. Sandeep Panikkar, who figured out all this, who developed the antibody. Now the question is, what about the alternative pathway? Factor B and factor D are absolutely critical for the alternative pathway function. And if either one's missing, you have no alternative pathway activation. So the idea is if you target factor B or factor D, you still can have the classical pathway, and you can still have some complement-mediated defenses, thus preserving an important element of protection against them. This is a very interesting experiment published by Novartis. The alternative complement pathway inhibition abrogates pneumococcal opsonophagocytosis, that's a mouthful, in vaccine-naive but not in vaccinated individuals. So what these investigators did is they took peripheral blood mononuclear cells and added the bacterium plus complement. And when they did that, with bacterium plus complement, all the cells are killed. The colony-forming units are way down. However, if they did the reaction where they blocked factor B or blocked factor D under the conditions where patients and not the individuals had not been vaccinated, their antibody titers were too low, and the factor B inhibition and the factor D inhibition was sufficient that the bacteria were not killed. When these individuals were vaccinated, then what you can see is the bacteria are killed. So what this means is you can, if you have an immunized individual, then you can block factor B and factor D, and the phagocytosis reaction will still occur, and this gives one confidence that this is a paradigm that makes sense. So what Novartis then did is they looked at 250,000 small molecules. This must have taken more than a couple of days, I would imagine. And they looked at the ability of these small molecules. They screened them for the potential to block the proteolytic action of a cobra venom factor B-sub-B complex. Fortunately, you don't have to hear about cobra venom factor today. If you go to a real complement meeting, it's all over the place. So anyway, they used the cobra venom factor there, and they got a hit, as it were, and they found that minor modifications gave rise to LNP023. And what I'd like you to see is that with the LNP023, they can completely block hemolysis of P and H red cells in the presence of serum. So this looks like a real winner. Targeting factor B, approved by the FDA for PNH in December 2023, based on the APPLY PNH phase 3 trial, And I'll just quote from the Novartis announcement: in the anti-C5 group, which was switched at 24 weeks to Fabhalta. Why there have to be 3 names for every antibody, I've never quite figured out, especially as I can't pronounce at least one of them. In any event, in the anti-C5 group, which was switched to 24 weeks to Fabhalta, mean hemoglobin levels increased to near normal, 9.1 at 24 weeks, anti-C5 alone, to 12.1 later. So that's really a remarkable and terribly exciting observation, I think. Targeting factor B for atypical HUS. This is a life-threatening form of thrombotic microangiopathy characterized by 3 observations: hemolytic anemia, thrombocytopenia, and acute kidney failure. And there's excess alternative pathway complement activation, especially on damaged vascular cells in the kidney. Red cells get clogged, get damaged as they move through, and so there's injury to red cells as well as platelets. And the underlying cause of the disease can include a variety of mutations in complement control proteins or autoantibodies to them. Well, a phase 3 trial will determine if the iptacopan, that's the second name, is safe and efficacious in atypical HUS. Targeting factor B for C3 glomerulopathy, and again, we've got the 3 names. It's characterized by kidney destruction due to excessive, uncontrolled deposition of C3 activation products in the kidney. It can have many causes, but it's usually autoantibodies to complement control proteins and or especially autoantibodies to the C3 convertase or the C4, the C5 convertase. They're called nephritic factors. A phase 2 trial demonstrated safety and efficacy of iptacopan in 27 patients, 16 naive and 11 who had received kidney transplants. So that is, and they also had lower levels of soluble C5b9, indicating again that complement activation had been abrogated. A phase 3 double-blind trial, 200 milligrams of the small molecule inhibitor orally twice a day of PRC3G has demonstrated clinically meaningful and statistically significant proteinuria reduction, December 11th, 2023. This is Richard Smith, surgeon, world expert on C3G, who has played a major role in all of this work. Finally, targeting IgA and IC-MGM. I already mentioned that. IgA nephropathy is the most prevalent nephropathy, and for reasons that are not clear, we develop our IgA1 no longer expresses galactose. We make antibodies to it, and these immune complexes deposit in the kidney. Positive results in a phase 3 trial have been reported, and a phase 3 trial for that looks very good. And then a phase 3 trial is now underway for the immune complex MGN. So it would appear that all these things are going forward and working well. Now the question is, can you only target factor B? What's the advantage of targeting factor D? And theoretically, the advantage is the same. The difference we have to recognize is the molar concentration of factor D in the plasma is 1/50th of the molar concentration of factor B in the plasma. So you have a much less target that you have to worry about if you're going to target factor D. And you already saw this slide. I apologize. But the bottom line is, if you look, if you look at placebo, nothing happens, whereas given dinocopan, which is the anti-factor D, you're doing much better. And then when the placebo patients are switched off over to the dinocopan, the oral factor D inhibitor, they look very good as well. So, is everything settled? Do we have to have a meeting next time? Based on multiple phase 2, phase 3 trials, blocking complement at several points is clearly safe. If vaccinations are included, there's one caveat. So then we have a decision point. Should we target factor B or factor D in alternative pathway complement-mediated diseases? I don't know the answer to that. I think Dr. Risitano is probably the only person in the room who knows the answer to that. In any event, second question, too much of a good thing in PNH, buildup of circulating PNH red cells, or in other complement diseases as well. How, based on that, how does one detect and or prevent breakthrough hemolysis in cold agglutinin disease, or PNH? And what about the resurgence of complement activation in these diseases treated with complement inhibitors? And then finally, those of you who have followed this field know that addressing the C3 opsonization extravascular hemolysis problem in PNH was like running a marathon. But Dr. Risitano persisted. And with that, I thank you for your attention.
Thank you very much, Ron. So now finally we have the pleasure to have Pedro Prata to talk about the germline complement gene variants in PNH. He's also from Hôpital Saint-Louis.
Thank you very much, Rodrigo. Well, first of all, I'd like to express my gratitude to the Foundation for the opportunity of being here today to present our study, and to say that it is truly an honor to be among you today. So as Rodrigo said, I'm Pedro. I'm Franco-Brazilian. That explains my weird accent, which is a mix of Portuguese and French. And I currently work with Regis in Saint-Louis Hospital in Paris, and we'll discuss germline complement regulatory gene variants in PNH. Well, C5 inhibition was a big game changer, as we have discussed today, for the natural history of paroxysmal nocturnal hemoglobinuria patients in increasing overall survival, increasing quality of life, reducing thrombosis. Unfortunately, more than a third of these patients will respond poorly to C5 inhibition, and some of these patients will present a minor response or no response at all. There are many factors that might contribute to this failure of anti-C5 treatment. And the first evidence of a germline factor affecting the natural history of PNH, and special of eculizumab response treatment, was published in 2014 by the Japanese team, when they have described that patients who failed eculizumab, they had a polymorphism on the C5 gene, and this prevented the correct binding of eculizumab and correct inhibition. And these patients presented persistent intravascular hemolysis. In the same year, a French-Italian collaboration have described the some polymorphisms on complement receptor 1 gene, and this was correlated as well with a poor response to eculizumab. So these polymorphisms were hypomorphic, and there has been a reduction of the expression of CR1, and that is the postulated hypothesis of why these patients responded poorly to anti-C5 treatment. For these two previous studies, there was no data showing that these polymorphisms or germline variants were overrepresented in the PNH population. We continued the idea of exploring why patients failed eculizumab. And we have studied 84 patients with classic PNH that were followed in the French Reference Center. All these patients had classic PNH, and they were under eculizumab when we started data collection. And here we were interested on other complement regulatory genes. Of note, C3, CFI, MCP, CR1, and CFH. Those genes were not yet discussed today. So going in a very fast forward speed for the complement cascade, focusing only on the alternative pathway. So there is this spontaneous C3 hydrolysis that generates, with factor B and factor D, that generates the C3 convertase, and this is regulated by CD55. And there is this positive amplification loop with more C3b that Dr. Taylor discussed has this role of opsonization. And this specific stage is negatively regulated by factor I, factor H, CR1, and MCP. And then there is the generation of C5 convertase that triggers the activation of C5 and the formation of the membrane attack complex. So we were interested in these negative regulators of the alternative complement pathway in this study. Well, just an example of C5 inhibition that inhibits the terminal membrane attack complex, but the opsonization of red blood cells persists, justifying the extravascular hemolysis. And, well, we have identified 19 germline variants, rare variants defined for this study with a mean allele frequency inferior to 0.1% in 16 patients. And strikingly, the most frequent gene affected was factor H. Factor H, that is one of the master negative regulations of the alternative pathway. And it's a cofactor of factor I, and it accelerates C3 convertase decay. It's a fluid and membrane phase negative regulator. And so when we noticed that, well, it was quite striking. We have identified that 9 patients among our 84 patients presented rare germline variants. And by germline, we have confirmed on DNA extracted from fibroblasts. We decided that it would be interesting to compare these frequencies with geographically matched healthy cohort and a public database. So we explored 80 healthy, a priori healthy individuals and the 1,000 genomes public database. And we have identified that these variants were much more frequent. They were overrepresented in the French PNH cohort that was treated with eculizumab than in the two control groups. More than 10% of classic PNH patients presented CFH germline variant, whereas less than 2% on the public database and in the control cohort. Then we tried to explore if the presence of such variants affected the disease presentation, but by the age, it seems that PNH patients with these CFH variants, the disease is diagnosed a bit later in life, but just in the limit of significancy. But there was no difference between patient sex distribution, the time elapsed from the diagnosis of PNH to eculizumab initiation, nor the coexistence of bone marrow failure. Hemolysis at diagnosis was comparable between the two groups as thrombosis before eculizumab or transfusion dependency before eculizumab as well. And what was striking, it was after the start of treatment by eculizumab. Because patients bearing these rare CFH variants, all of them failed treatment with eculizumab. This is non-adjusted analysis. Well, only 9 patients had these variants in our cohort, but all but 1 were still transfused after the initiation of anti-C5 treatment, and 2 among these 9 patients presented thrombosis after the 4 weeks of loading dose of eculizumab. And just a teaser for another study that was presented last year in ASH by Dr. Carlos Bravo Perez from Dr. MBChB's team, and I think it's a poster here in this meeting as well, that they also have identified that some CFH variants were overrepresented among PNH patients as well. And they compared with aplastic anemia. It was more frequent among PNH than in aplastic anemia. And patients with aplastic anemia bearing complement variants, they had a high risk of evolution into PNH. And this, I think, that adds to the body of evidence that still, if PNH is an acquired disease, there is an influence of germline factors that were not known a few years ago. So these body of evidence supports, that germline factors interfere in the pathophysiology of the disease. We have identified that CFH factors were overrepresented, and it gives the idea that it does play a role in the pathophysiology of PNH, although this role thus far is not known. We still don't know all the roles of factor H and PNH pathogenesis. Patients with rare germline CFH variants did not respond to eculizumab, we need to validate that in a larger cohort since we could not adjust for confounding factors such as patient age and previous transfusion. But I think that once this data is validated, we could discuss that upfront proximal inhibitors for such patients could be discussed, and contrary to what was just discussed. I'd like to thank you all for your attention and my mentors. Thank you very much.
Thank you very much. And, have a seat. Thank you very much, Pedro, for your presentation. So I think that the session is open for discussion and questions.
Can I?
Of course.
The question I'd like to ask, and I don't know I've seen this published at all. Are there any feedback loops? In particular, let's say that you're blocking C3, all right? If you block C3 real well with the Lambrus peptide, do the levels of factor B and, the levels of factor H and factor I go down because C3 is blocked anyway and you don't need the natural inhibitors. And this issue might obtain for whatever complement pathway that you're blocking. That is, do the other inhibitors that are now superfluous, do their levels in the bloodstream go down? So instead of looking necessarily for a mutant in factor I or factor H, shouldn't one also, when one's blocking complement, measure levels of factor H and factor I in the bloodstream? And maybe Antonio knows the answer to this.
No, I don't know the answer. I can tell that Veronique in Paris is working on that, looking for different biomarkers, looking for biomarkers of complement activity, like CH50 and so on, biomarkers of complement activation, breakdown fragment like BB, BA, and also, which is a kind of broader view of your question, the levels of all complement proteins, because we also have that the level of the target may change. We know that, for instance, by targeting C3, we may have increase in C3. This was shown for C5 as well, and we have no data on factor B and factor D. So these are exactly the open question and the kind of investigation that we should look for in the next coming months, in my opinion. And I think Pedro has some additional answer.
Thank you. So we have discussed that for patients with terminal inhibition, not proximal inhibition, as you have proposed. The difficulty, when I discussed with Veronique, that is, she proposed that to measure the activity of factor H instead of just the antigen of factor H. The problem was that she is unsure what is the domain that is chiefly active in factor H for PNH, and if we can assess all these specific different functions of the factor H. And we still didn't have an assay to measure all the different possible activities of factor H. And in special to our study, there were some VUS, some variants that were deemed not pathogenic. However, they were in regions where we do not know what is the specific function of the protein is, and so she could not develop an assay to measure specifically this factor H activity.
And sorry, Pedro, if I can further elaborate just for hematologists, is that factor H has two different functions because it serves as cofactor just to promote the dissociation of the C3 convertases, but it's also it serves as cofactor for factor I and as promoting the promoter of the dissociation of the convertase. There are some in vitro assays developed by the Penn University John Lambrus lab when they were working on mini factor H, but again, that was never used in clinical samples. Phil?
Yeah, it's a fantastic panel, great talks. Really enjoyed all of the talks and the interaction. Regis, you emphasized that you should act early for breakthrough hemolysis. I think you said that a couple of times very forcefully, and we understand that. but 5 minutes? That's that's pushing it. I mean, you don't have time. I mean, based on your talk, you said 5 minutes, all the opsonization and the red cells are gone, and you show apoptosis and beautiful graphics. But from a clinical perspective, that's kind of too quick. I don't. Can you comment on?
Yeah. So for the complement level,
Well, the question
They
is,
take a pill, right? Pill. They can take a pill.
Well, I'll see the answer. I don't know what the answer is going to be.
the
I mean, I was encouraged by your talk, but
Oh, no.
discouraged by yours because
a lot of
5
people
minutes.
criticize my talk, it's okay. I know, but the question would simply be, are there other markers that occur, that would be evident before catastrophic breakthrough hemolysis occurs? And that would be the question. And the patients might not want to be monitored very often, but it would seem that if you could look for these warning signals, then you have a much better chance.
yeah, I mean, we learn how to manage those patients, and I think that we were used to manage breakthrough under C5 inhibition, and honestly, it was not so quick. We were having time, or at least we were able to react quite lately, 2-3 days, that was okay. We are changing paradigm in a way that the patients, when he's presenting, I mean, we're educating patients when he's presenting any complement amplification conditions, whatever. We are reacting quickly by, shortening the frequency of the injection and possibly transfusing and a backup of C5. If you are in a way of educating patients, reacting quickly, you see the real world data, you see the clinical trials on breakthrough hemolysis management, you may work well. The only thing is that you have to react quickly. But I mean, it's not 5 minutes, 10 minutes, it's 1 or 2 days, yeah.
But Regis, if I can join all the talks also here, when you mentioned the pegcetacoplan study and you had the breakthrough hemolysis in 13 out of the 48 patients, so they were almost 40 episodes, but they were restrained to a specific minor set of patients. There was anything specific about them, or that you could think of genetically or clinically that, or environmental that could predict that?
Yeah, so this is, of course, a very good question that we spend hours to discuss with Antonio, and it's very disappointed, but not speaking with Antonio. No, because we were, of course, looking for all factors that might be predicted, or factors you may say, the patients, I mean, those kind of patients are gonna probably do some very severe breakthrough. The only thing that we find associated and was the fact that the patients who were highly transfused before, so 3-4 times a year before go to pegcetacoplan. And the other thing that we found, but it's not a large number of patients, is the patients who are not fully blocked under eculizumab. So in other words, those ones were with the CH50 that were dosable before going to proximal inhibition. So in the end, I'm sorry to say, because this is very imprecise and a bit rough, but the most severe patients that were coming to proximal inhibition were the most transfused and the less blocked by eculizumab.
But not marrow failure, right? If I can make a correspondence, they had a more aggressive disease in matters of hemolysis.
No, but it's another pathophysiology, and then I'll let Antonio complete. Marrow failure is just the fact that the patient has a marrow empty, so he's not overcompensated the hemolysis that is on the other side. But it's really another mechanism. It's not involved in the severe breakthrough hemolysis we're observing under complement proximal blockage.
Thanks. Beautiful talks. Thank you so much. I learned a lot in this session. My question is for Dr. Frieri. It's a clinically oriented question. So if you have a patient with PNH who presents with aplastic anemia and you're intending to bring them to transplant, is there a role for complement inhibition as a bridge to transplant? And keeping in mind the patient is clearly severely neutropenic, would be at risk for meningococcal infection, extra bad heading into transplant, but also at risk for thrombosis. How do you balance those risks and benefits, and what's the role for bridging C5 inhibition?
Thank you for the question. So in my clinical practice, I had one patient that was on ravulizumab. We decided to do the last dose of ravulizumab during the conditioning regimen, as we can see also from the series, from the literature. We know that all patients on complement inhibitors are vaccinated before starting, complement inhibitors. This is how we managed in this case our patients. After transplant, we try to check PNH clone on peripheral blood and also signs of hemolysis, to be sure that there was no a PNH clone after transplant. But we stopped ravulizumab during conditioning regimens.
Yeah, but again, wonderful talks. Question, you show the example of I believe, rituximab, right, and CLL. I happened to treat a couple of patients who had CLL and were on complement inhibitor, so they were unfortunate enough to get both disease. Similar story is with ATG. Of course, patient is on stuff and on complement inhibitor, and we always ask our question, will ATG still work? And in both cases, I have to say that the treatment worked. In other words, the complement-mediated lysis of CLL cell is not important because otherwise, so it's most likely opsonization, it's most likely FC phagocytosis mediated, and the same with ATG. Would you agree, or?
The evidence is very good that the main mechanism of action of rituximab is FC-mediated removal of targeted B cells to the liver and spleen. However, ofatumumab and rituximab was not approved by the FDA as a single agent because it didn't work. Its ability to activate complement is lousy, actually. Ofatumumab is much better, it binds closer to the cell membrane. Ofatumumab was approved by the FDA as a single agent for chronic lymphocytic leukemia. So there it does have much more of an effect. But rituximab, it's just FC.
And another question is, thank you for showing our poster and, beautiful data. But provocative question would be, what gives us PNH or what gives us aplastic anemia? And the question is whether a polymorphism in complement pathway are not necessarily or may affect the clinical presentation, big hemolysis, quick progression, slow progression, brisk hemolysis, etc., versus whether them by themselves are a predisposition factor to aplastic anemia. And maybe you have the data. Carlos is here. He can comment on it too.
We don't have the data. We discussed it many times, and we do not have any strong biological hypothesis to justify why these variants were overrepresented among the PNH patients. The impression we had on the clinical effect is that this was uncovered by C5 inhibition, and there was no difference in clinical presentation. And patients with CFH variants, they were diagnosed later. There was a 10-year difference gap between patients with wild-type CFH or rare germline variants.
How about thrombosis?
The same. No difference in thrombosis, no difference in transfusion dependency at PNH diagnosis or eculizumab initiation. But there was this 10-year difference gap. That is, the median age on the wild-type group was 35 years to 45 years in the CFH group. I do not have any biological hypothesis.
I mean, the biological hypothesis, and you can dismiss it. But if there is a complement-controlled pathogen that people who have a hypomorphic polymorphism in one of the complement pathway activating, potentially is needed to remove it, then of course such individual would be more susceptible to maybe more fulminant infection or to the different pathways that the infection take care takes place, different sites in the body. So this clearly could predispose to, in aplastic anemia in general.
Yes, well, in my understanding, these initially we suppose they are hypomorphic variants of factor H. They would make that the alternative pathway to be more active, so leading to more hemolysis. But well, perhaps these immunogenomic crossroads might contribute to the pathogenesis of the disease, but I do not have any further data on that thus far. But we can work on that together, and that would be a pleasure.
We have another question.
Excuse me. So this question is for Dr. Camilla Frieri, if I'm saying that correctly, as well regarding transplant, and it's also clinically oriented. So a couple of things. One thing is that graph that you showed us with survival with the two approaches to conditioning with myeloablative versus reduced intensity. They were similar as you followed them out, but the myeloablative arm indicated some early toxicity in TRM with these patients, transplant-related mortality. So there seems to be some sort of a signal there. My other question is similar to what Jill just brought up, wondering about the role of complement inhibition pre-transplant as a bridge, but even peri-transplant. And I'm curious because you noted that the patients tend to have infections in GVHD. So I think that might be an interesting thing to think about, and whether these patients maybe are at risk for TMA, which is can be a pretty awful transplant complication too. Have you seen anything about that?
Thank you for the question. The first one, as I can say during my presentation, I think it's very difficult to, to give a definitive answer. Also, when we have to choose between conditioning regimens. We know that PNH is not a malignant disease. The goal of the transplant is to eradicate PNH clone and to reach a full chimerism donor, probably with a low toxicity. But I think it's difficult, to do a definitive answer about that if I have to choose between myeloablative or reduced intensity regimen. About the second question is about how to manage eculizumab, if I well understand.
Yes, it's just
okay.
Regarding the complement inhibition approach peri-transplant in these patients. As I try to explain during my presentation, I try, to revise the previous literature about that. And there are a lot of different approaches about how manage eculizumab in pre-transplant and post-transplant time, because we don't have guidelines about that. Probably the most common approach is to give the last dose during conditioning regimens, and after to check PNH clone and signs of hemolysis. In the literature, there are, I think, about a few cases that eculizumab was used also after transplant, because the PNH clone size was high also after transplant with signs of hemolysis. So it was a good option for the patients or to reduce the possible complications related to hemolysis, like thrombosis. Thank you.
Okay, I think we have to close. Before that, I just wish to have you remembering Regis' word about breakthrough hemolysis, because you mentioned that the risk is higher in patients with uncontrolled C5 blockade, right? But we know. Well, basically, we don't know anything about uncontrolled C3 blockade or factor B or factor D blockade. So this is the missing information nowadays. We know perfectly what are the mechanisms, the molecular mechanisms leading to breakthrough under anti-C5 treatment, but not on proximal inhibitors. We have no idea whether there is some bypass of C3, factor D or BB or any other mechanism, or just a PK issue. So this is what is missing nowadays to better understand the biology of that. And with that, I think we can close the session, right?
Yeah, thank you all the speakers. And yeah, we return at 4:10. Thank you.
Thank you.
Thank you. Bye.